So you know what? So recently I had gone for one of these outreach clinics and I had met a very senior doctor, and he was like, Dr. Saab, lung, pancreas, and stomach. I don't even consider sending them to you because I tell them, anyways, there's not much that you're going to be able to do.
Oh my God.
And I was like, sir, so then I started telling him about how the last decade has been, right? So 2013 probably, so that's when we first started having these EGFR inhibitors, no? So at that point, I think a uniform recommendation, or the way we would tell patients the outcome was that if it's stage 4 lung cancer, that you have around 6 to 12 months, right? So that was for almost everyone. And
Everyone.
yeah, and only then we started seeing the effects of drugs like geftinib and erlotinib, and then we would have these few patients who would live for slightly longer than that. Then we started seeing them, live for like 2 to 3 years. I told the doc, there is this new drug called lorlatinib, and the most recent results that were published, especially in the small subset of ALK positive patients, which although it's like a very small subset of the lung cancer patients, they had this 7-year data where those who survived the first 2 years, right, almost 80% of them made it to 7 years, and they're expecting that they're going to probably live more than a decade. So that's how things have changed in lung cancer and stage 4 especially. So I thought today we'll just talk about how things have changed with lung cancer, not just in terms of treatment, but also looking at how screening options are now available, and how we categorize lung cancer, and then we'll finish it off with like treatment options. So again, World Lung Cancer Day is on August 1st. Yeah, so what has your experience been like? I mean, we trained in different institutes, and yeah.
So probably when I was a resident, and the stories I heard is institute gates were closed if you once say it's a stage 4 lung cancer. That's it. And we used to declare people death, in matter of no time. And this is what we heard. And then it's like, the thinking, not one size fits everyone, right?
Yes.
So the mutation testing, it became, the hot topic. And then in particular, geftinib, we used to start, we didn't use it, we waited, and, non-smoker, female, typically presenting. Geftinib is only go-to. And then by the time the results came in, things just flipped. Patients became better.
Yeah.
They came a year, then they were coming till 4 years. And then it's a major shift.
Yeah. So so again, when we're talking about gates closing and all, I think it's more to do with the fact that your institute was funded by a lot of donors.
Sure.
So it was like you had to make best use of whatever money that was given, and then that was mostly for curable malignancies, and we would not prefer to use it for those who are stage 4. But of course, like you said, things change. Another interesting point that you made, that you would see these patients who are like less than 50 years, probably female, non-smokers.
Typical.
Yeah, so that is that subset that we look out for, right? Even before the testing, we kind of know that they probably have this particular genetic change, which will allow them to be a candidate to receive one of these drugs. Women, household, getting exposed to all this biomass, smoke.
Yeah.
Of course, now with gas cylinders being a thing and millions of families getting access to it, that is probably coming down. And also
changed a little, but this incense things which are happening in the closed doors for a long time. Previously it was all open.
Yes,
Apartments, culture came in, everything is closed.
So burning incense sticks inside.
Yeah, and which is also adulterated.
Now I think this generation, if they want to smoke, the husband is probably going to step out, go to the parking lot and smoke. I think in the past they wouldn't care. They would probably just smoke, and second-hand exposure to smoke was what most women, had to deal with at home. So maybe we can talk about like what the impact of smoking is on lung cancer, right? About how there's like an increased mutational load and that impact.
Right.
Because I have so many friends of mine, okay, they'll be like, see, so many people are getting lung cancer even despite not smoking. I might as well just smoke and.
So probably, as it said, 1 pack of cigarette, one which is having a day, which has like 20 cigarettes. We label it as a 1 pack here,
Yes.
of course. And then the more you smoke, it's like a person who is having it over 20 years, say, has it 20 pack years. This increases the risk significantly. What people think is, if it is very importantly these days, vaping. They are thinking that I've stopped smoking, I've gone to vaping, and
Yes.
this is, making me no risk exposed,
Yeah.
right? So I would like to say, if you stop smoking for a while, which is equal to 5 years, at least if you're stopping for 5 years, you are still at risk. Only if you've stopped for 15 years,
Yes.
your lungs are equal to a normal person lung of your age
Yeah.
and exposure.
So basically, we're talking about like pack years. Whenever we take smoking history, we ask them how many cigarettes they smoke in a day.
Yeah.
And then we kind of convert that into something called as pack years.
Pack years.
And then if they've had say more than say 20 pack years, then they're candidates for screening and they have much
Yeah.
higher risk of lung cancer. And like you said, no, there's a lot of change in forms of tobacco really, right? So smokeless tobacco, and then you have vaping. And again, the data, when smoking cigarettes was in vogue, it took decades for them to actually realize that that's a carcinogen, right? So I think we're in that phase with vaping.
Vaping now, yeah.
Where
and shisha and also the hookah.
Yeah, so shisha hookah was like a big thing in our college days. So very community kind of
Peer pressure, it would put us.
not pressure, but then it's like there's always one fad that's in vogue like in each decade, right? So smoking was in fashion, then hookah and all of this. Now it's vaping. So we still don't know the impact of vaping in the long run. It would take like maybe another decade of research for us to actually start seeing the impact of that on cancer. At least for now,
Right.
I talk a lot to my pulmonology colleagues. They're like, forget about cancer. They see a lot of young, those who vape come with severe lung disease.
EVALI.
Probably not even related to cancer, but they do come with that.
EVALI, lung injury because of all this.
So again, when we mention pack years, like why are we talking about pack years? Like what can, so say I'm like, and I'm in my 50s and I've like smoked away for more than like 20 pack years.
You do.
So what is there anything that is there any way that I can detect lung cancer even before I start to have symptoms? Because let's face it, most smokers, they have chronic cough. So coughing is not a new symptom.
It isn't made up to the government screening guidelines though, but as a private practitioner, I would always err towards doing a low dose CT. Low dose in the sense that, the exposure, the radiation amount that is given to the person is less, and also the number of cuts. It would give me enough of idea that yes, a mass is going to start there, or a mass which requires a biopsy is sitting in there. This would alert me as a clinician. So yes, I would refer them for a low dose CT.
Yeah, so low dose CT again, anyone who's between the age of 50 and 80 who's had like more than 20 pack years of smoking, and or the equivalent, and or those who continue to smoke, or maybe they've quit within the last 15 years. So they're candidates for low dose CT, like you said.
Very right.
And the whole concept is basically people are worried about radiation exposure. And because it's an annual recommendation, you get this low dose CT every year. You don't want that to kind of itself have a negative impact. So we've kind of figured out a way where the radiation exposure is much lower than your standard CT. And then that's when we kind of pick up lung cancers at a stage where they're still curable. Right. So that is definitely one thing. I think that's one of the themes of this whole World Lung Cancer Day, where they want to see this low dose CT being offered to a lot more than what's being recommended right now. But I think the other challenge really, right? See, in a lot of other cancers, you kind of have a cause and then you have an effect, right? Unfortunately for lung cancer, what's happening, because there's so much lung cancer in non-smokers, that there are a lot of studies ongoing where they're trying to see if they can make low dose CT screening a part of regular screening guidelines, not just in the high risk population, because there are so many who don't smoke but they still end up, right? So I think we still don't have data on that. For now at least, high risk, we do have a screening strategy.
I'm looking forward for that, the
Definitely.
major change in the screening program should come with this.
Yeah, so also like we spoke about how smokers already they have a cough. So if I'm a smoker, right, when should I be concerned about that possibly being something more sinister than maybe just my regular chronic cough? So basically any cough that is, there's a change in the nature of the cough, like it's more frequent, your bouts last longer, you're probably having it even when you're sleeping, and there are there's probably no trigger for that cough,
right,
like before, or like you said, chest pain, breath, all these associated symptoms where you're falling out of breath and then obviously coughing out blood. So these can indicate like advanced cancers, and obviously time, right, if it lasts for longer than usual. So whether you're high risk or you don't have any of these obvious risk factors, the important message is that you don't ignore these symptoms, right? So say I were to come to a hospital with any of these symptoms, like how would you go about evaluating me? Like what are the tests that you would do? Is like a chest x-ray enough, or would you do anything else?
Okay, nothing beats physical examination. I would initially do that, the general clubbing and all this, and then I'll go for the respiratory examination, all said and done, and then next. Yes, X-ray probably a mass, it should be reaching more than like 3 to 5 centimeters, and then a pleural effusion. Only these two, very evidently show me that.
So basically fluid around the lung, right? So pleural
effusion means a
layer,
fluid, a layer which is covering in between your chest wall and the lung. There's a layer, and that is filled with the, fluid, which is because of the malignancy. So only these things it can indicate. But yes, then when something is wrong, I would definitely go for a CT, which will show me the location, accessibility to do, is it a bronchoscopy I need, or it's only through the periphery I can get the tissue out for the biopsy. All these things that gives me
so basically you would want to image, and like you said, in an X-ray you can find it. You can find changes like in advanced stages where the size is quite big, or fluid has already accumulated around the lung, but then you would want to do something like a CT scan, and based on where that particular problem is, like it can either be outward, closer to the periphery as we would like to call it, or maybe central, closer to the airways. So I think that's like one of the big improvements in the past decade. Because in the past, we did not have this whole interventional pulmonology concept, right? We had a lot of our senior consultants who are trained in pulmonary medicine, who would see a lot of tuberculosis. And then also a lot of patients would get treated with empirical tuberculosis, which would later turn out to be a malignancy. But now you have this whole generation of interventional pulmonologists who are so so they have different ways that they can get to even the tiniest lesions that are probably even like a centimeter, where in the past it would be impossible to do that, right? So like you said, depending on where it is, if it's like quite in the external and there's no rib obstructing, we could try to get a biopsy from CT guidance, or maybe if it's more central, closer to the airway, then we would have to do a bronchoscopy to try and get a piece of tissue basically to try and make the diagnosis. So again, I think one of the things that our patients are concerned about, right, is time. Like in the past, from the time you made your diagnosis, you would just have to label it as either say something like a small cell lung cancer and a non-small cell lung cancer, and that's about it. Adenosquamous, and then you go about treatment. Now our patients are being told to wait for much longer before we can start treatment even, right? So maybe a little bit about what all we do with the kind of tissue that we get in the biopsy.
Yeah, like I was telling, it is nothing like previously, not a one size is fitting everyone. We typically understand, through all these years, we understood that there's a driver, typically some mutation, some change in your blueprint of your cell, which is making the cells move around and mutate and divide into the umpteenth number of times. So that driver mutation needs to be picked up. Right? So when I take out the tissue, just that I cannot rely on, yes, there's an adenocarcinoma, there's a squamous, I'm going to do this. And so the math has changed, the algorithm has changed. Now I would send for preferably a NGS comprehensive or at least a solid tissue panel, and I would know what it is.
Patients always tend to equate, injectable chemotherapy with the one that has the most effect. But if you have to be a candidate for one of these tablets or even immunotherapies that we're talking about, you would have to have all of that information. So that's what I tell them. It's like if I start you on treatment on day 1 without having adequate information, there's going to be a time frame before you can get your next cycle, right? Say I get all the information in the first week, and then I start you off, you might not even need to receive any injectable chemotherapy.
It's an unnecessary toxicity, right?
Yeah.
So that their apprehension of not getting treated within a week, will the tumor increase? All these questions we have to face with
So
them.
that's what, just to summarize, so it's basically we have to do a biopsy.
Yes.
First, we kind of determine whether it's something like a small cell lung cancer, which is like a completely different entity, or non-small cell. And then again, after non-small cell, adenosquamous. And that is what the pathologist tells you after they look into the microscope. But then there is a whole set of tests that we send out with next generation sequencing and IHC, where we kind of know all of these mutations like EGFR, AL, CROSS, MET, RET. So this sounds like a lot of jargon, but I'm just trying to, give you a sense of how many different mutations or these genetic changes can dictate what treatment is to be given, and they also give us so much information as
Which
to
are targetable, very important.
So it's
many
like
drugs newer coming up.
you have this target, and then you have a drug that is going to work for that particular mutation, right? So we give them not just the treatment option, but we also kind of tell them, because there are some subsets where we know that, okay, fine, you're probably not going to respond that well to treatment.
Yeah.
Also, a word about immunotherapy, right? So immunotherapy is like big in oncology in the last, I think, a decade, and now in the lung space,
It
not
changed
just
totally.
so not just in advanced malignancies, right? Even in earlier stages,
Perioperative, preoperative.
Adjuvant. So, and I think a lot of patients. I remember, I even last week I had a patient. He was like, I'm looking at stage 4 lung cancer, and then he's on tablets, right? And I think he had some financial constraints. He was worried about having to continue the same. And then he's like, doctor, I don't know what you do. I at least want to live for another 10 years, and then, so even I think patients' expectations have gone up because
tremendously high.
So people like us are talking about, how things have changed.